Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. In today's episode, we discuss current trends in SARS-CoV-2 and risk factors for severe COVID-19 progression. I'm joined by three expert faculty, Dr. Cristina Mussini from the University of Modena in Italy, Dr. Martin Witzenrath from the University of Berlin in Germany, and Dr. Michele Bartoletti from the IRCCS Humanitas Research Hospital in Italy. This episode is part of a larger educational program entitled COVID Rounds, Clinical Case Discussions on Best Practices for Inpatient COVID-19 Management. For more information on our faculty, along with a link to the larger educational program, please visit the link in the show notes for this episode. Now here's Dr. Mussini to get us started.
So let's talk now about the current SARS-CoV-2 trends. First of all, it's important to look at the variants of concerns. So what are those that are circulating now? From a situation where there was, in a way, the domination of one of the VOC, now in the most recent month, we have seen that the situation is more mixed up. What is more important to understand is that all these variants, they belong to the same Omicron lineage. And this is very important because we know that Omicron really changed the pattern of the disease, because Omicron is very infective, so easily transmittable, but mostly it's localized at the upper respiratory tract. So it can determine lower respiratory tract localization, especially pneumonia, only in people who are really immunocompromised. Among the variants, there are a couple of variants that are for now under monitoring by EU, and they, as you can see, they all are Omicron, and the lineage BA2.86, KP.3, and XEC. We don't have a lot of evidence about these variants. And especially, we don't have important information about the impact on severity, because it seems that there is no impact on severity. So we continue to monitor, EU is continuing to monitor, but for now, we don't have specific alarm that has been raised. As I said, in most of the people who are not immune compromised, these variants determine a sort of influenza-like syndrome, flu-like syndrome, with cough, with cold, running nose, but not what we have seen at the beginning with, for example, with Delta. What we can see is that in vulnerable patients, the situation could be different, because not only we have the acute infection that could also exacerbate chronic illness. Let's think, for example, at those with who have a chronic bronchopathic disease, for example. But also, we know for now that after the acute phase is resolved, we can have a post-acute severe sequelae. The association of hospitalization with COVID, you can see since the beginning, we have seen that age was a major factor of severity in COVID-19. But still today, we are talking about from March 2020 to April 2024, still today we see that the older age is probably the most relevant factor that influence hospital admittance. It will be important to discuss about it, because many times COVID in these patients just represent the cherry on the top of other diseases, other comorbidities, and not really a lung involvement. Very important data arrived to us from the INFORM study, that is a cohort of immunocompromised patients followed in the UK. It's obviously a retrospective, but the numbers are very relevant. As you can see, we are talking about almost 500,000 immunocompromised. And the immunocompromised that represented 3.9% of the study population, they accounted, despite the low number, of them among the general population that was affected by COVID-19, but they they quoted for 21, almost 22% of hospitalization, for 25% of those who had more than 3 vaccinations. So it's not that they do not try to protect themselves, but unfortunately, they account for almost 24% of death, and among also those who had more than 3 vaccinations. So we have to consider, even when we talk about the risk in immunocompromised, that immune compromise could differ. And the one with the highest risk are those who are taking anti-rejection drugs, those who bone marrow transplant or hematopoietic stem cell transplant, and those who had a solid organ transplant. So if we look at the risk factor, some of them, they really dates back at the beginning of the epidemics, because the age, as I said before, has always been associated with a worse prognosis, but also medical condition. If you remember all the cases with diabetes, with hypertension, that here is not listed, but I remember in the first paper by the Chinese authors, hypertension, that is so common, was one of the worst risk factors. But also kidney disease, obesity, unfortunately, how many people, also very young, but who were obese, died of COVID-19 during the first phase of the pandemic, and then also pregnancy. Obviously, we are talking about a virus that has been defeated by its mutation, I would say, because it has become less, prone to go to the lung, but also especially by the vaccination. So the status of the vaccine of the patient is very, very important. And it's important to understand how many doses the patient had. And then the status of the immune system, because as we have said, higher risk in people that are immune compromised or receiving immune suppressive medication, for example, those with anti-rejection drugs. So which are the immune compromised who are at elevated risk for COVID-19 infection and complication? Those who are at high risk, obviously, are those with a lung functionality that is in a way compromised, so severe respiratory disorders, some rare blood disorders, rare metabolic disorders, diabetes treated with insulin, significant developmental disabilities, pregnancy with serious condition, neurological impairment. All these situations could be listed, for example, for flu, could be listed for severe bacterial pneumonia. I mean, there are these people, such, a clinical situation that is so compromised that an acute illness could determine really a severe disease, even if in immune competent people, it doesn't end up like this. Then we have moderately immune compromised. So cancer, we have seen in the previous slide that I showed you that cancer patient had a higher risk of severe disease, but not comparable with other situations like bone marrow or stem cell transplant or solid organ transplant. So we are talking about a moderate risk. Immune suppressive therapies. HIV, there has been a huge discussion about HIV less than 200, but especially those who are like late presenters, so not with an undetectable viral load, because we really have seen, even during the pandemic, very rarely patients with this situation. And moderate primary immune deficiency and dialysis or severe renal disease, that we have seen so many patients in dialysis or severe renal disease. But who are the ones that are really at higher risk of a bad prognosis are the ones with hematologic malignancies with active treatment, stem cell transplant, anti-CD20 agents, and B-cell depleting therapies, solid organ transplant, severe primary immune deficiency. Those who are severely immune compromised are really those where we should not lose any time, I think, in prescribing antivirals. But we have to think also about antiviral treatment in the other two previous conditions. So, moderate and medium risk. Because we know that, for example, we talk about cancer, and we have seen that, for example, if someone has no cancer, the risk of hospitalization or mortality is almost non-existing. When we go to solid organ, there is a higher rate of hospitalization and a very little higher risk of death compared to the general population with no cancer. But it's when we go to hematologic malignant neoplasm we see the difference and a statistical difference. There are multiple factors that may affect why they are at risk. If we are talking about these patients who are severely immune compromised, we know, as the patient who talked during this webinar, we know that they vaccinate, they do a lot of doses, they do all the possible doses that they can. But unfortunately, when you are immune compromised, your response to vaccine is impaired. And there are multiple factors that may affect vaccine efficacy in chronic lymphatic leukemia and in other lymphoid malignancies. There could be vaccine factors, so dose intensity and frequency if they don't vaccinate. Patient factor, age, comorbidities, hypogammaglobulinemia, treatment factor, like, also doctors, they say watch and wait, or maybe they have been previously treated. And all these factors, there is a reduced number of people that mount an immune response. There is still there we have to understand if the antibody titers are protective or not, how much do they last. So if there is a persistence of these antibodies, and the result is that there is a reduction in the clinical incidence of infection in a way. I mean, if we can provide these patients with some other, for example, protection, as we did with the antibodies that now are not used anymore, but we did the monoclonal antibodies in many of these people, in many of these populations. But now we don't have very effective ones, so we don't use them anymore. But the only way to reduce the clinical incidence of infection in those who could not respond to vaccine is to have alternative strategies. So if we have to discuss, I have talked about how to determine patient at high risk for COVID-19 progression. So what do you do? Does it matter how immunocompromised they are? What are other criteria aside from immune compromise that you consider? For example, being old or other risk factors? Do you do?
I think here we can rub up a little bit what we just said and heard. And I mean, obviously, age is an extremely important risk factor, and the comorbidities are. And of course, the question, how immunocompromised is the patient? And if there is no B cell and T cell response, then this patient might be in a very high risk situation. That's the general perspective. And then, of course, we have to look at the patient in a personalized way. And as I said, look for the Quicksilver criteria, the oxygen saturation, the PCO2, serum lactate, question whether the patient has renal failure or other comorbidities. And then, of course, the question, how immunocompromised is the patient? But maybe Michele wants to add here.
Yeah, I totally agree with you and with Cristina. I think that, as previously said, when we talk about immunocompromised patient, we have to consider which is the underlying disease, but also which is the program of treatment. Because I think that, said Cristina, we have also to consider that this patient needs continuous treatment. So besides underlying disease, also we have to consider the program of the patient. And additionally, all treatment should be considered. And probably now what we're seeing, especially in hematological patients, is a lot of different treatment that they go. For example, lymphoma patients, they can receive standard chemotherapy, then they go autologous transplant, and then they go to CAR T treatment, and then they can fail CAR T, and they still have bispecific antibodies. And then again, allogeneic transplantation. So I think all these can have a really altogether can higher really the risk factor for COVID progression. So again, personalized treatment according to patient history and clinical features are very important. Is very important in my opinion.
Yeah,
I think at that point, if I may add that, we have to consider to talk to the people to the colleagues who are dealing with the patient and their general underlying disease. So in our specific patient, we obviously would like to speak to the hematologist and ask, how important is it now to continue the therapy? How quickly do we have to get back on track? Do we have some time to react here? And what's the perspective of this patient? So the multidisciplinary approach here is particularly important, I guess.
Yeah, I was thinking also in the compensated diabetes, for example. So it's important not only to think about, the intensivist, or the pneumologist, but also to think, all the other comorbidities that could have led to a severe picture. So I think that this is very important, as you said, the multidisciplinary approach.
Thank you to our faculty, and many thanks to you, our listeners, for joining in. As a reminder to view the full program, COVID rounds, clinical case discussions on best practices for inpatient COVID-19 management, please click on the link in the show notes. And to get access to all of our new podcasts, subscribe to the CCO Infectious Disease Podcast on Apple Podcasts, Google Podcasts, or Spotify. Thank you, and have a great day.